Very good morning to all of you. So the title of my presentation is about caring for patients with dementia and providing palliative care. To understand providing palliative care to patients with dementia, let's see the story of this patient, Mr. George. Mr. George is 81 years old, retired teacher, lives with his wife Susan. Dementia was diagnosed 5 years ago and has gradually been deteriorating. He is now dependent for all aspects of care. He just passes urine, incontinent of urine and feces. He doesn't tell you, he just passes in his diaper. He is finding it difficult even to talk. He's just barely walks 2 to 3 steps at a time, where that too with support. So most of you must be knowing about dementia, but just to put it all together, give the perspective. What do you mean by dementia? Dementia is a progressive, irreversible clinical syndrome characterized by widespread impairment of mental function. Now, if you notice, I have highlighted few things here. First of all, we have to recognize that dementia is a progressive and irreversible. It's progressive. People, in the initial phases of dementia, they go for all desperate measures in terms of taking medications and everything. Yes, it may slow down the dementia, especially I'm talking about the dementia which is not, suppose there are different causes of dementia. Some dementia we can arrest, but most dementia it is progressive. And it leads to how impairment of mental function. And that can be very distinguished property, or distinguished presentation is memory loss, language impairment, disorientation, personality changes, difficulties with activity of daily living, self-neglect, and sometimes some real psychiatric problems. So why are we discussing dementia here in a palliative care forum? Just to make a point, it is so common. Prevalence increases with age, they say. 40 to 65 years, 1 in 1,000. Above 85, 1 in 5. And once a patient is diagnosed with dementia, yes, they live long, but median age length of survival from diagnosis to death is 8 years. Like I said, it is a progressive, life-limiting condition with prolonged and progressive disability and complex need. It is very complex. I feel sometimes cancer is much more easy to manage. Dementia is so complex with so many complex needs. Let's look at the physical problems of advanced dementia. When I say it's very complex, if you see, they have such high symptom load, and at the top is confusion. Imagine a patient in your family who's confused all the time, he's just totally not there. It's such a difficult thing to handle. They become incontinent with urine very soon. Very surprisingly, pain is very common in dementia, and the mood change happens very frequently. They get constipated because of various reasons, and they have a lot of feeding issues, including loss of appetite. As I said, pain is very common in dementia. They give a wide range, 36 to 50%, and it increases, and the severity of pain also increases. One study showed that 50% of patients with dementia experienced pain in the last 48 hours. Why I am discussing this is that because it is a very well-known fact that overall the evidence is sufficient to conclude that the risk of underdiagnosed and undertreated pain in people suffering from dementia is unacceptably high. It is so common, but it is underdiagnosed and undertreated. the caregiver stress. I don't know whether you have had any personal experience of seeing a patient with dementia in your family or in your neighborhood. This is a highly stressful job for the caregiver. And they themselves are very vulnerable to stress, depression, feeling of guilt, and other psychological difficulties. And it is 24 hours, 365 days, like it's continuously. It's not like they sleep well and you're sleeping with them. And there's a lot of burden associated with their mobilization, transfers, toileting, feeding, all of these issues. They have to do it all the time with the patient. George, with progressive dementia, in the last 1 year, he was seen by general physician, urologist, cardiologist for various reasons. It's a very predictable thing, what happens in a kind of life cycle, as the disease progresses, what happens with the disease like dementia. There were 3 admissions to the hospital in the last 12 months for pneumonia. He aspirated again and again, and he had developed problems, and he was admitted again and again. The last admission lasted 4 weeks. After each episode, he did not recover back to the point he was at before. The question often asked is when to refer to palliative care. Because in early stage, we are still looking at arresting the progressive nature of dementia, arresting the progress, or trying to look at any correctable, and many of these things happens in the early stages. So, and the problem is that often there's confusion around, okay, when to say, now you need palliative care referral. There are some general indicators when you know, okay, this is the time he's having advanced dementia and I need to refer. But this is what one of the SPIC guidelines. So this is an entire website around SPIC. They have developed guidelines for different kind of disease conditions where when to refer to palliative care. And as they say, as you see for dementia, think about palliative care if the patient has these general indicators: unable to dress, walk, or eat without help, eating and drinking less, swallowing difficulties, urinary and fecal incontinence, no longer able to communicate using verbal language with little social interaction, fall with fractured hip, again and again falling, recurrent febrile episodes or infections, aspiration pneumonia. So when you see these conditions, it's time you know that, okay, he's having progressive dementia, and it will be helpful if he gets palliative care support. I would have discussed this in one of the previous sessions. Surprise question is one more trigger which will help you to make a decision. Okay, now this patient, I think he needs palliative care. He's progressing towards end of life care. So ask this question: would I be surprised if this patient died in the next 12 months? If your answer is yes, think about palliative care. Again, if you're not still very sure about when to refer to palliative care, they say the general recommendation is it should be need-based. Forget about all those indicators. If you think this patient has need, this patient has pain, recurrent infection, problems with bowel bladder, getting bedridden, bed sores, aggressive behavior, think about palliative care. So it can be need-based. So what do we do in palliative care? Like I said in one of my previous sessions, we call it as patient-centered dementia care. It should be patient-centered, everything around patient. If you look at this picture, it talks about the changing care goals and priority through the course of dementia. If you look at your left side, as the first time the diagnosis is made, when the patient is well and maybe you're suspecting, okay, this patient you have a probable query of diagnosis, talk about health promotion, prevention, risk reduction. As the disease progresses, In the mild stage, you're talking about prolongation of life still, reducing risk reduction, prolongation of life, health promotion, all those things we're still talking about. As the disease progresses, then you start slowly looking towards maintaining the minimal function, activity of daily living. Towards the later part of dementia, the whole focus is maximizing the comfort. So if you see how the goal of care changes over a period of time. And I think from mild to moderate, the shift happens, moderate to severe, you think about palliative care. And when the death happens, after the death, caring the family who are grieving the loss is known as bereavement support. So this is the changing care goals through the course of dementia and the priorities. What do we do in palliative care? Domains of holistic assessment starts with assessment. Any care starts with holistic assessment. So what is the thing which you would assess when you're managing patients with dementia? Of course, the background information and understanding what is happening in terms of his disease condition. What are patients' preferences? Remember, I said patient-centric care. So the goal of care should be revolving around patient's preference, patient's physical needs, patient's social and occupational needs, psychological well-being, spiritual well-being, and life goals. So the whole care plan will depend upon the assessment which you make in all these domains. Now these domains and the need may change as the patient's disease trajectory changes. Psychosocial care. Often it is seen or believed that when the individual with dementia becomes immobile, aphasic, and totally dependent, you think, oh, this patient needs only nursing care. No, they need much more than that. The sad thing about dementia is that what we call it a social death. The person, your identity as a person, as me, my identity, it dies much before his actual death, biological death. He ceased to exist that as a person. Often I hear from caregivers looking after patients with dementia that he's no more the husband which I seem to know. He's not at all, he's totally changed, he's different. Because they're reduced to totally different personality, and that is known as social death. But we have to remember that even in severe dementia, the possibility of emotional distress must be considered. They may not express, but they are worried, they are anxious, they lose control. So they are so emotionally highly distressed, and high prevalence of depression in dementia. So even in the later stages, attempts should be made to communicate and understanding what's happening to the patient. Dementia is one disease condition where it really raises the deep existential issues to do with life and relationship. What is the meaning of life like this? I'm so dependent on others. The change in relationship, you change in dynamics of the whole life around you. And that leads to a lot of existential questions about meaning of life. Why me? Why is God punishing me? So it should be explored and supported. For many, religious belief may be helpful. For many, it may not be, but we have to be mindful of that. Coming back to George, as I said, his disease is progressing. George is now deteriorating again at home. He had not eaten for a week. Very minimal sips he takes. Very sluggish response. Seems to be in discomfort, frowning and mourning, especially when you move him, trying to change his bed sheet or turning him around. He's mourning and frowning. Pain in dementia. Like I said, it's quite common to see pain in dementia, especially in a progressive advanced dementia. But the problem is that these patients cannot express. A healthy patient, if they're in such pain, they will shout and make sure that they are attended to. but these patients cannot express. So how do we make sense of what is happening to them? What we have to understand, that why I'm again and again coming back to pain, is that how pain can affect the quality of life. Very often when I see patients with advanced dementia and the family tells me, I don't know why last few days patient has become very aggressive and patient is resisting even to move. When the moment I try to change him around, he's becoming very stiff, and he's not letting me move, change him around, turn him around. Always look for pain in that situation. More aggressive behavior, more resistance, think about pain. And pain can also affect the sleep, mood, eating, mobility, behavior, and vocalization. Either they become totally withdrawn if they have pain. Sometimes they start showing abnormal vocalization. So these symptoms, if you see, look for pain. There are some pain tools specific for patients with dementia which can be used, especially if you're dealing with many patients. Maybe make it a routine screening to use such tools to look for pain. Look for some potential source of pain in such patients, which can be surgery wound, bed sores, contractures, blood tests, past history of back pain, neck pain, maybe that is still there. So look for potential causes of pain. Family members can give you a lot of history. So look for the surrogate reporting. They can tell you, yes, whole night he was moaning in pain. And encourage them to report to you when they see any change in behavior. Whenever they notice any change in behavior, ask them to report. Generally, assume that he has got pain. If you're not very sure, give a therapeutic trial of analgesic, which can help you to make a diagnosis. So normally what we start to do is we give a trial of paracetamol round the clock. It's a simple medicine. You can start with that, and you will notice that how patient becomes suddenly nicely quiet, nice breathing, relaxed breathing. He looks relaxed, his frowns have gone. So it can be a good diagnostic tool to use a therapeutic trial of analgesics. The role of clinically assisted nutrition and hydration in people with dementia is very controversial. Often a lot of pressure will be there from the family. How can you just not feed him? We have to do something about it. But before you even talk to the family about these issues, you have to know that there is no evidence that tube feeding can improve functional nutrition status, skin integrity, functional status, or whether it can prevent aspiration pneumonia or improve comfort or prolonged life. Any of these things does not happen with tube feeding. In fact, they say that when you do tube feed, there's a greater chance of aspiration. So dementia and nasogastric tube feeding and advanced dementia, more and more people are doing away with it. It's not recommended. In fact, when you forcefully feed the patient doing such things, you are adding more discomfort to the patient, and risks such as risk of infection, fluid retention, edema, pain and discomfort, frequent hospitalization. Suppose you decide to put him on PEG tube, complications of PEG tube, and increased aspiration. So even in advanced late dementia, they say that this whole thing about artificial feeding and hydration, the conversation should start early. It should start early, preparing them. You know what? His disease is progressing. Very soon, he may not be in a condition to eat like before. So have you thought about what is that you would like to have? Have you discussed this with your patient? What does he want? So they will tell you. He said, don't put any tubes if I think worsen. So remember I said, look at the patient's preferences, values, cultural context, and take a decision. But remember that it does not help. It adds to the more to the distress. So this conversation should start early. They say hand feeding, it's helpful even in most advanced stages. They say that it is found to be most human and effective method of feeding even in advanced dementia patient. It promotes the sensory experience of food and touch. They may keep the food in the mouth for a long period of time and then slowly swallow, but that is fine, because the progressive weight loss which you see in dementia is not because he's not eating food. It's a general deterioration of condition. So by providing artificial food or hydration is not going to make him gain weight. In fact, adds to the problem. That family should understand, because often they become very distressed, and that becomes a core source of distress for them. Dying in dementia and advanced care planning. Studies have found that patients with dementia compared to cancer, they are more likely to experience uncomfortable or aggressive intervention at end of life, like in terms of blood test, intravenous therapy, arterial blood gas, feeding tubes. Despite the wish of the majority of dementia patients and their families to die in their homes, most die in the hospital. Now, this all stems from the core issue, bad planning, because we fail to recognize as a progressive condition, and this discussion doesn't start early on. This discussion around advanced care planning, goal of care, treatment, treatment, therapy, even nutrition and hydration. If you start this conversation early on with advanced care planning, allowing the individual to express their desires and choices for future health and personal care, when a person cannot make or communicate their decision. You may think it's very painful. How can you start this discussion? But you actually are doing good to the patient by doing this. So it's strongly recommended. So when to initiate this end-of-life care discussion and planning? There's no right time. Start conversation as early on in the disease process as possible, when the person may still be able to voice their hopes, wishes, and what is important to them. That is the time you should do it. Think from George's point of view at this point of time. What does he want? George would like to die at home. He would like to die surrounded by his family members. Surely he wouldn't like to have symptoms, though he can't express. But if suppose he could express, he would say, please take away my pain. He would like his priest to be around, say prayers. He would like to make his will prepared, funeral arrangement made so that he doesn't burden his wife, who is also very old. Susan is very old. Imagine, George is 81, Susan is she's 72. So helping Susan to make this kind of plan will help Susan later on to do it, deal with this function or rites, rituals, everything which is required to be done after George passes away, and giving him that dignity which he needs all his life. He was a school teacher. He lived his life in dignity. And even in the end, he demands that dignity. Imagine from Susan's point of view, what is that Susan wants to, what does that Susan want? She wants to understand what is going on. Somebody please tell her what is happening. How this disease is progressive. George is nearing his end of life care, and let's see what is our goal of care. Tell him all that. She may have questions like, how can he be dying? Doctors told me his lungs and hearts are fine. I don't understand. I thought you need heart attack, stroke, or cancer to die. I never thought it would be so soon. She may be saying all that because dementia, nobody recognizes, as I said again and again, it's a progressive event. So having this conversation with Susan would involve explaining that treatment in hospital is unlikely to be successful this time and may prolong suffering. Explain the normal process of dying. Ask Susan to talk about what George wanted, what were his wishes, what were his preferences. Reassure her that we'll try our best to help him remain calm and peaceful for whatever time remains. That would mean a lot to both Susan and George. Find out how she is coping. Who is the support system for her? How much is the family supporting her? So it will be very helpful to understand this and help Susan in undergoing this whole stress of dealing with dementia. The loss which happens with dementia can be very painful because it's a prolonged period, 8 to 10 years of caring, and suddenly the person is no more in your life. Suddenly you feel lost because your whole life for last 10 years revolved around that person. Morning getting up, okay, I have to feed, I have to change him, I have to do this, and then suddenly he's not there, and they don't see any purpose in life, and they feel very lost. So when you're helping these people, you have to have a program of bereavement support in your dementia program. And the grief of loss starts quite early, even before death it starts. We call it as anticipatory grief. Like I said, social death. The person ceased to be the person he was. The wife doesn't recognize him as her George. That is known as anticipatory grief, the grief of losing that person before death. And high risk for the family or for Susan to develop complicated grief. Grief can be normal grief, complicated grief. When we lose somebody, we grieve. There's a period during which we feel sad and we cry and we grieve. But many times, people don't cope well with the loss. And they develop a lot of psychological morbidity, like depression, anxiety, taking alcohol, doing drugs, these kind of issues. So that is known as complicated grief. And these people are very high risk for complicated grief. Many of you are working in hospitals and you're involved in policy decisions. Suppose your hospital is working with elderly population and dealing with dementia. You have to understand why. First of all, you have to agree that people with dementia in your program need palliative care. All people with dementia will at some point of time require palliative care. But when once you agree to that, you have to look at what are the barriers to providing palliative care to such patients in your hospital. There are several barriers: policy-related barriers, education, communication, attitude. Policy point of view, if you see, if you don't have a policy about palliative care in your hospital, you may not be able to provide palliative care. That is obvious. Insurance does not cover palliative care. If there's no advance directive, you'll end up in trouble because of legal issues and whether you don't know whether to put him on ventilator or not. It's very time consuming. That's what people think. Yes, which is true. And if you don't have proper one-to-one staffing for these kind of patients, they will not get the optimal care. From education point of view, the doctors, nurses, the staff looking after such patients, they have most of the time, even I never had any kind of training about understanding dementia, prognostic uncertainty, when to recognize the terminal event, when to recognize dementia as a cause of death, how to assess distressing symptoms, what is the law and ethics around that, and what is palliative care. All this education is seriously lacking among our staff. And so when you're planning dementia care in your hospital, a comprehensive care should involve palliative care, and your staff should be adequately trained. And once you get trained, then the whole thing about communication starts. Then you can communicate well with your patients and families, and your attitude will also change. So how do you provide a patient-centric care plan for George with progressive dementia? Coming back to George. If I had the choice, I would have had early integration of palliative care to George care in dementia. Aggressive symptom control, assessment and symptom control. When the George was still cognitively all right, I would have had advanced care planning and shared decision making based on George and his family's wishes, preferences, and values. If I had done that, maybe I could have had a good end-of-life care planning based on his place of preference. George had expressed that I want to be in my home towards my end-of-life care. I would try to provide that home-based end-of-life care as much as possible. I would have looked for providing adequate psychosocial and spiritual support to George. And I would have really wished that we had provided better support to Susan during the caring for her husband and the bereavement support after his death. Thank you.